So good afternoon, everybody. Good afternoon. Thanks for joining us here at our third town hall this year in 2025. I want to first of all say thank you to you taking the time out of your busy schedules. Thank you to all those veterans out there for serving our country. Appreciate that. And happy pre-Thanksgiving to everyone who's listening. We're across the country today and almost in transatlantic. We have about 120 folks signed up and about 10 countries around the world represented in 30 states. But we're here today to talk about what I consider the backbone of sort of when I was getting taken care of, the nurse corps that is out there across the globe, just helping patients that don't get the recognition all the time. And so I'm really excited to hear today from everybody and hear some inside stories that we didn't hear about. So today's title of our third town hall is Your Oncology Nurse, a key partner in navigating kidney cancer care. And we're joined by a great moderator, Marge Karras, who's one of the board members at the the Oncology Nursing Society, along with two great panelists, one from Tampa from Moffitt Center, Gigi Jamil, as well as her colleague all the way from the Los Angeles area at UCLA, Nazi Zamaradian. And they're going to take it over and just talk about a lot of different topics. We got questions from around the country. I'm going to get off stage and let Marge take over here. And thanks again for joining us, everybody. See you at the end. Marge, it's all yours.
Yeah, great. Thanks, Brian. Nice to be here, everyone. So as Brian said, my name is Marge Karras. I am an oncology nurse. I have been for quite a while. I've been working with patients since really in oncology back since 2001. So today we're going to be having a discussion between myself, Gigi Jamil, and Nazi, I can never say her last name, apologies, Nazi Zamoradian, who all are very experienced in taking care of oncology patients as well in different nursing roles. So we're going to go through a few themes today and kind of round robin talk about issues that we think are going to be important to patients, but specifically really understanding the role of the oncology nurse and all of the different aspects that includes. So we're going to start out with really just the core of understanding what the role of the oncology nurse is and kind of describing those different roles. So I'm going to start out kicking it over to you, Gigi. Can you kind of explain the different types of roles nurses have within the broader care team in oncology nursing for kidney cancer patients?
Yeah. So in our clinic, we have an RN who is a clinical nurse, and she helps to support the patient. We also have nurse practitioners, and we also have nurse navigators. Nurse practitioners like myself, I see patients typically after the physicians see the patient to establish care with the patient. And I monitor things like quality of life, labs, treatments, scans, those types of things. The RN who works with the patient is probably the first person to meet the patient in clinic, even before the patient sees the physician. So the RN will introduce themselves to the patient, get them oriented to Moffitt Cancer Center and the services that we provide. Also, the nurse navigator is another component of our nursing team. And the nurse navigator is in touch with the patient before they even walk through our doors. So it helps to navigate the correct physician clinic they need to be in and all of the records that need to come with that patient.
Great. Yeah, it's a complex role. Nurse navigators really are kind of the detectives in patient care. Nazi, can you explain a little bit too around some of the roles you see within nursing? I know you play a pretty big role in research. Can you kind of also talk about what that looks like from the nursing perspective, especially as it would relate to a patient coming in?
Of course. Thank you, everybody, for joining us. This is a really important subject, and hopefully we have people around the country and they're asking the right question, which it brings us to the patient care that is always really the center of what everybody does, no matter what their title is and what they do and their job description is. everybody's that is in the center of care of the patients and obviously the patient's family. The role of the nurse in oncology, it's been redefined throughout the last 3 decades because we changed the way we treat cancer. Used to be not a lot of options out there. We had the limited resources of medication, and it wasn't a lot to navigate. Now that we have a lot of options and so many medications that they're actually personalized for different stage of the kidney cancer, the role of oncology nurse is evolving to being, as it says in the name, navigate them through the process from A to Z. And the oncology nurses are very in tune with what's happening, what's new. And I think that in academic and private practice, the nursing is also shifting to make it every patient's personalized experience because not one fit all. And so the role of the nurse as an oncology nurse, as an infusion nurse, as a navigator, as a clinic nurse, and it's always is to connect the dots or help the patients to actually get the layout of what is next and how we can help you to get there.
Yeah, great. Thanks for that. Kind of thinking too about how nurses and their different roles kind of help patients to navigate the entire journey of cancer care, from even symptoms to diagnosis all the way through treatment, side effect management. We know, I can say specifically being a bedside nurse for many years, that patients tell us many different things than they tell other pieces of their care team, especially their physicians. What type of things do you see that patients talk to you about or mention to you that maybe they don't mention to when they're seeing their main oncologist, whether it's in the clinic or inpatient? I'll give one quick example. Is I was in the clinic and I had a patient come in who was taking one of the early TKIs, and he was telling me how he's still working and how terrible things were and how he was wearing gloves when he was there. And when he took them off, he had some really terrible hand, foot, skin syndrome. Like his hands were just almost just losing skin, and he put his gloves back on and was like, don't tell the doctor, I don't want to stop my treatment. So things like that. Like, what else do you kind of see that maybe is unique that either patients confide in you, or you just kind of end up having a different type of conversation with patients? And I'll start back with you, Gigi.
Yeah. So I think that as nurses and nurse practitioners, there is a lot of relationship built up between us and the patient. And we also have more time to spend with our patients. Typically, the physicians, are seeing back-to-back patients in a busy clinic, and maybe they only have 1 or 2 days of clinic. And in our practice, our nurse practitioners have 4 days of clinic. So they get to spend more time with the patients. And so as you build that relationship, you learn things about patients that they don't tell their physicians, not just things like side effects, but also like, oh, my daughter is getting married next year, and I really want to be healthy, and I need to learn how to dance. And, if I have blisters on my feet from a TKI, I can't be dancing. Like, how am I going to do this? So things like that are things that when you really start to get to know people, you hear about and you can intervene on a different level, I think.
Yeah. Anything to add to that, Nazi?
Sure. And I think that trust, which Gigi mentioned, and the building a relationship with the patient and their caregiver and family is important. And I think the other thing is constant education. Just because you said it once and you talked about the side effects and how we're going to manage it, that doesn't stop you to just keep saying it. These patients, they're in a lot of distress. Obviously, you know, nothing is more important than your health, and now it's being jeopardized. And all these people have their lives, you know, like you mentioned, you know, they have events coming, and they wanted to continue life, and they wanted to be as healthy as possible. So I think each one of us in every step when we see the patient, I think that there is really no limit at how many times you're going to repeat yourself, how many times you're going to reassure patients that these treatments that we have experience with, we know how to deal with the side effects. You just have to let us know. Most of these patients, if they're on oral medication, unfortunately, we don't see them in the clinic as often as somebody who's coming for infusion. So I think that we have to keep the communication line open. You have nurses that they calling the patient, asking specific questions, and make sure that they know that we're there to help. And if they don't tell us, we don't know. So then they are going to get into more trouble than they need to be with the side effects and other aspects of their disease.
Yeah, thank you. Yeah, and that's kind of the perfect segue into our next topic, which is managing treatment and side effects. As Nazi just mentioned, that's a critical part that I think probably our whole audience knows. It doesn't matter how great your medication is if you can't stay on it. So kind of in that same thread, talking about, we know that there's several types of medications for kidney cancer patients. As the market's evolved, thankfully, and we've had more science really understanding some of the different mechanisms to treat kidney cancer. So we have things such as immunotherapy, we have TKIs, we now have drugs like belzutifan with HIF2. So kind of thinking that all of those in mind, what are some of the most common treatment side effects you're seeing specifically in kidney cancer patients? How do you manage them? And what do you say to patients as far as the importance of reporting these side effects? And so I'll start that with you, Nazi.
Well, as I said, that sometimes we victim of our own success. Obviously, all this research, clinical trials, and years, it gave us a lot of tools, a lot of new ways of treat kidney cancer, as well as the other cancers. And now we're trying to do less harm and more targeted therapy, which is gonna actually just aim this to the tumor, but not other cells. And but still, if you get any drug, you always have a side effect. If the drug has an effect and it goes through your bloodstreams and doing something good, obviously there's something bad is coming with it. Now, how bad it is and how we're going to control it, it's really important. And I think different drugs, they have different class of side effects, and we become very knowledgeable in the last decade to deal with those side effects. And as you mentioned, it's hand and foot skin reaction. You see high blood pressure, high blood glucose. So these are the things that we keep track on the patients. We checking their blood work, and also we really relying on patients reporting these side effects. And obviously, as I said, each drug has its own class of side effects, and each step of the way, any nurses in the clinic or navigators or IPPs in the clinic, I mean, if you ask the right questions and give them the right tools, then you can actually keep these patients on this drug for a very, very long time and get the efficacy that we all see on those, charts and reports, that they become very effective.
Yeah, and so Gigi, what are the most common treatment side effects that you're seeing in your clinic for patients going through kidney cancer treatment right now?
Well, like Nancy said, it depends on the class of drugs. With immunotherapy, we typically see colitis, and we also see rashes. We do have some patients that spill over into having diabetes that never
Can
had
I
diabetes before.
can I ask you for the patients here who maybe don't know that term or know what it looks like, can you explain what colitis is?
Yeah, so colitis is just really bad diarrhea. And it's awful. And that can happen with immunotherapy. That can also happen with the TKI drug class. So those are the pills that we have you take for the kidney cancer. And that is a big side effect that patients typically are very willing to discuss because it really impacts your quality of life. Like I see somebody has put in the chat that, yeah, it's definitely not fun. No, there's nothing fun about it. Another side effect with the TKIs, those pills, is high blood pressure. And that is something that patients don't typically want to talk about because it doesn't impact your everyday quality of life like colitis does. Another side effect is hand foot syndrome. So when you get like the blistering on the palms of your hands and the soles of your feet, like we talked about earlier, like Marge was saying, she had that patient who was wearing gloves because he was trying to hide it. That's another big side effect that we see on a daily basis in clinic.
Yeah, I think it's hard, right? Because it is that delicate balance of wanting to be able to help patients stay on their medication, but also making sure that there's a quality of life. There's a reason to be on medication. And I think that having those communication with the patient early on about number one, like you mentioned before, Nazi as well, what are your goals of care? Is it, is it to go dance in a wedding? Is it to, what is it? Because it's different for every single person. And so how aggressive you might be in managing those is going to vary from patient to patient. I do want to call, we do have a question from the audience. Peggy Z from Kansas, did you want to ask a question?
Yes, I did, but it happens really to be from another patient who, for I understand reasons of her health, couldn't be here today. And it's a basic one you've been discussing. How do you start the discussion in regard to balancing quality of life versus treatment?
Yeah, that's an excellent question. I'll kick us off with saying just kind of what I had just said is having that conversation with the patient from the beginning and regularly of what's important to you, what are your goals, and really making sure that you understand how your patients are truly feeling as they go through the course of therapy. And then so I'll ask you, Nazi, how do you do that in your practice? How do you have those conversations about quality of life and manage kind of dose reductions or taking breaks?
I think that it all goes back to the education and being completely open and honest with the patients. Each patient, that they're actually have to be treated as their intelligent being, not just a patient and subject. So I guess that we do have a lot of tricks that we learned over the years that to actually help these patients to prevent things to happen. So we always become very proactive. Like for instance, if I start the patients on immunotherapy, I tell them that you can start hydrating every day. You can be very cautious about drinking enough fluids, stay away from the fatty food, dental hygienes, oral hygienes, don't use anything contain peroxides or alcohol on your skin. Use a different lotions that it's kinder to your skin, stay away from the sun, use the sunscreen. You know, all of these little tricks, even though that they don't seem like very elaborate, and but it does actually help, and it helps to two things. First, patients feel like that they're in charge, they're doing something, they're in control, they can actually contribute to prevent this to happen. And then if they're aware, then they check their own skin. And if they see something is happening, then they report it earlier. And I think it's our job to make sure patients feel comfortable to coming forward with the side effects as soon as they appear, because when they're in actually better stage and earliest stage, we have more tools and we can prevent it to get worse. And the patient definitely will have a better quality of life. And the other thing I always tell my patient, I said, don't fight with your body. If you're tired, you're tired. This is your time. When I'm tired right now, I can't just say, oh, I'm sorry, I'm going to go take a nap. But you have a really, really good excuse. Don't fight with your body. Your body is going to tell you exactly how you should feel and how you're going to feel. If your body telling you take it easy, take it easy.
Yeah, thanks, Nazi. Gigi, anything you would add to that about how you have these discussions with patients and kind of balance dose reductions and you know, interruptions in therapy?
Yeah. I mean, I agree with Nazi very much so that the earlier that we can have these discussions, the better the outcomes are. So if we discuss, hey, how are you feeling about X, Y, and Z now? And start bringing up, do you have a cough? Could it be related to pneumonitis? Are you having any diarrhea? Are you checking your blood pressures at home? And we start to bring those up on a regular basis and we start to talk about those things. I think that it's a lot easier to manage the side effects when they're first starting out using like dose reductions or even just holding therapy for a week or so to see if it resolves. Um, and even doing a holiday, like I have a lot of patients. I mean, I live in Florida, so everyone's going on a cruise or something. And they are all like, well, can I just stop for a week so I can feel good and eat whatever I want on the cruise? Yeah, absolutely. We're doing this so that you can live your life and have a good quality of life. And like you said, Marge, having those discussions early on is better to see, what we're doing this for.
Yeah. I did want to go back. There was a question earlier in the chat too, where someone was asking what is the difference between a nurse navigator and a nurse case manager. And I'll kind of chime in from my experience, which is a lot. They're very different, distinct roles. A nurse navigator, they're kind of like your one-stop shop in a lot of institutions. So they're the person that, especially if you have a lot of specialists that you see, which most patients do, they typically are the person who kind of keeps track of all of that for you. It's almost like they're your own personal admin and they know you and they know what you need. And there's someone you can call and say, hey, this is what's going on. And they can help facilitate the conversation with whichever specialist it needs to be and still make it feel like you don't have to do all of the work and running around to figure out how to get things. Now, nurse navigators work closely with nurse case managers. Nurse case managers have a lot to do with resources, especially if you're transitioning from like inpatient to outpatient or to assisted living or a facility. They're really good at resources and making sure that you kind of have all of those needs met to be safe and taken care of and able to afford your medications, all of those pieces. Whereas my experience in nurse navigator has been really more of kind of a holistic kind of umbrella for the patient. Would you agree with that, Gigi, or do you guys use them differently at your institution?
No, I do. That's almost word for word what I was going to say. It's from an inpatient perspective, I think that the case managers are really like the backbone of trying to get a patient out of inpatient and into either the community back home or into skilled nursing or whatever it is they need. And the nurse navigators, I feel like are like the orchestra coordinators. Like they're like, okay, you need this now and you need to see that specialist soon and let me help you get to that.
Great, thanks. We do have another question from the audience. It's Tracy from Ohio.
Okay, hi. Thank you very much, everybody, and thank you for taking my question. You've hit a lot of the TKI side effects, so I'm going to ask you a follow-up to that. If someone's considering belzutifan as a next treatment, how hard is it to manage the anemia and hypoxia that are frequently associated with that class of drugs? Thank you.
Yeah. Thanks for the question. That's a great question, especially since this is one of the newer drugs on the market. So there is a lot of, I think, just unknowns, especially within the community, just because not that many patients have taken it and been able to share that story yet. So I'll start with you, Nazi. Have you been treating patients with belzutifan that you can kind of talk to treatment management?
Yeah, sure. We did actually, we were part of the clinical trials when, before it got the FDA approval. So we got a lot of experience seeing and handling the side effects. And it's the good thing that if you actually get belzutifan as a treatment plan, to get it in a setting that people have experience with using it before, and they have also the care team that to go with it. I mean, oncology team is the greatest, but as we learned in the last 2 decades that we really need to have other people as an essential part of treatment plan. We need to have endocrinologists, we need to have the GI specialists, we need to have dermatologists. And with belzutifan, it's really important to have a good hematologist in our team as well. And I think the baseline is really important. We have to make sure that the patient does not have any anemia or any of the lab abnormality going into it, and treat those conditions before the patients actually get their first dose. And I think that, again, I am very relying on the patients always to tell me what's wrong. So to teach the patient signs and symptoms of anemia. If you feel tired, don't just say, oh, well, it's just my cancer. Sometimes tiredness is a sign of having anemia and low hemoglobin. Dizziness, headache, these are the signs that it says that hemoglobin is going low. So the sooner we catch it, then obviously better. And then if it happens, then we do use a lot of transfusions, and it works. And I really hematological toxicities is become part of this treatment. And I think that if we found a balance of really catch it early and treat it with a simple diet, add iron to your diet, add a supplement, all of those is actually, again, small steps that help to manage the side effects with belzutifan.
Yeah, thank you. Gigi, have you had any specific concerns with managing belzutifan, or any tips or tricks that you use in your practice?
Yeah, all of my patients who are starting on belzutifan, we also did the clinical trial. We were one of the sites, and I tell them all to have a pulse oximeter at home, which is those little devices that I think during COVID times we all figured out what those were. that you put on your finger, and they tell you your pulse ox level, which is like your oxygenation. I counsel everybody who's on it to do those, and I give them parameters for, you know, if it's under 92, you need to give us a call. Do it twice a day. Um, and then we also, like Nazi said, we talk about the symptoms of anemia. We're very lucky here because we're a big cancer center. So we have easy access to things like blood transfusions and procrit transfusions, which we can do to help support and bring those anemia numbers up.
Great. So we're going to move on to our next theme, which is nutrition, mental health, and whole person care, which I think we've kind of already been talking about the whole person. That's really kind of the core of nursing. But we're going to start off with a question from the audience from Merrill in Georgia.
Hi there. I would like to know what you counsel patients about regarding special diet for kidney health.
Great. That's it. Thanks for that question. That's a great question. Before I kick it off over to them, I'll say there's a couple of factors to consider. If someone is having a very difficult time eating while on therapy, anything is better than nothing. So if you can only handle ice cream and that's the only calories you get, it's better than no calories. Certainly there's a way to have a well-rounded diet, but you know, if that's all you can get in, your body still needs the energy to be able to, you know, breathe and live and do all those things. So I'll let Gigi talk, but that's just kind of my beginner take is something is always better than nothing.
Yeah, Marge, my go-to is ice cream as well. Also, if patients are having a lot of nausea and vomiting, and this goes for all of my cancer patients, I say, you know, ice cream tends to taste the same coming back up as it did going down. So that might be an easier thing to manage if you can't handle it. We also talk a lot about, in my clinic at least, sugar. And well, I can't have sugar because sugar causes cancer. There's really no evidence that sugar causes cancer. It doesn't feed the cancer. Um, I counsel all of my patients that everything in moderation is okay. Because, like, to go back to what I said before, if you're going to limit yourself on your birthday to not having a bite of your birthday cake, I mean, what's the point? Why are we doing this? We want you to have a good quality of life. Like, we want you to take your grandchildren out for ice cream occasionally. I want you to have a glass of wine with your spouse. I think it's really important that everything in moderation and that food doesn't become like an enemy, that you need to withhold things from you.
Yeah, I one of my soapboxes is I think that probably everybody's seen, you know, those viral posts saying, you know, don't eat sugar, it's causing your cancer. And I think we know obesity is linked to cancer, right? And we always associate, you know, eating a high amount of calories, whether it's from sugar or not, to obesity. But I think, you know, it really comes down to that basic biology of how your body takes things that you ingest and turn it into energy. And really, whether it's sugar, fats, protein, it's the same process in the body. It's just a matter of how much energy does each produce. So, you know, in the long run, does sugar feed cancer? No more than anything else. It's really just the process of how the body works. The next question I think is perfect for Nazi because I know her background and some of her thoughts. But can you tell us how you address nutrition and lifestyle questions that your patients raise, and kind of how do you guide them towards like resource and health groups, kind of to help support them in that, you know, lifestyle?
You know, the definition of health in the general sense is obviously you have to be active, don't be a couch potato. At some level, you have to move around. And I agree that you have to have a balanced diet. But unfortunately, there is a lot of information out there that a lot of people actually have access to, and it does not being driven from any clinical trials or research or have really a basis to it. And I guess that in every stage of the cancer, you need a different thing. If you're actually just diagnosed, obviously you may be healthy to some level and you haven't really got any treatment. And if you're already starting with some kind of problems like high blood pressure, obesity, or diabetes, obviously that's not a good start, because now you're getting ready to take and embark into going to surgery or receiving treatment for your cancer. So obviously we have to address this in a different way. Now you got the surgery and they got 18 centimeters tumor and your kidney out, and now you have only functioning with one kidney, and we're trying to get your kidney into the process of healing, the one you left. So then you need a different nutrition, you need a different movement. But a rule of thumb is that if you do not have colitis, that means like you have a diarrhea 4 or 5 times a day, you know, and you're just trying to eat healthy. Eating healthy is just to basically have all the food groups in your plan, and don't cut out anything, because that it's causing some kind of fat problem that it's out there. And I think that what I tell the patients, which is the oldest nursing tricks in the book, that they say to eat 5 or 6 little meals a day instead of sitting and eat 3 big meals, because your body cannot just take that the heaviness of eating the big meals. But if you do have favorites, I know everybody's ice cream, but just, you know, you love burger, make a huge burger, cut it into like 6, 7 pieces, and then have it during the day. You know, this way you're not eating in one setting, one big meal that makes you full and sick and nauseous. And then you get, you know, and don't go all the way in the other health side that, oh, I'm not eating any dairies, I'm not eating any sugars, I'm not eating any fat, I'm like cutting off everything, because your body is already shocked with getting the disease, and now you're cutting off everything your body got used to. I think your body is going to be very angry with you, and it's going to show it to you that it's going to backfire.
Yeah, it's hard to juggle the changes in having a new diagnosis and a new treatment, and then also trying to completely disrupt your life with a new diet on top of that. You know, we all only have such a capacity for change before it just becomes overwhelming and too much, and something has to give and break, and it's better to you really need to make some changes to do those in incremental steps versus everything all at once. And which kind of transitions into how this topic also includes mental health, because I love with food. And for me, food's a very important part of mental health. You know, it brings us a lot of joy and satisfaction. And with that, you know, nurses have kind of a special role, because we do spend so much time with patients, and we can't have time for those extra conversations that we do oftentimes recognize when patients are struggling emotionally, as well as caregivers too, right? This isn't a disease that only affects the patient. Everyone around them, their support system certainly is impacted by it as well. Gigi, how do you approach family members and patients to talk about support? How do you recognize or approach the subject if you think somebody's struggling? Kind of what do you do from there?
I give a lot of background when, you know, I won't approach that on the first time I'm meeting the patient. I try to develop those relationships. I see my patients typically every month, if not less than that. And once you get to know somebody, you can kind of see on their face when they walk in the door, hey, something's not right. What's happening? And I bring it up like, hey, I know it's a lot. Like, you started treatment, you are walking into a building that says cancer center in huge letters on top of it. That's enough to give anybody anxiety. And, you know, if this is like a daily thing that you're dealing with, well, what do I eat and what my blood pressure, and I don't feel good. I'm having diarrhea. My feet hurt. Those things can help build on your mental health and create problems. So I bring it up like, hey, this is the background. Everybody who walks through these doors already will have baseline anxiety. And then forgive yourself a little. Like, this is a lot for one person to go through. Even as caregivers, this is a lot to go through. Like, the person that you love most is walking into a cancer center with you and has to go there once a month indefinitely. That's a lot. Or you see them and they're being sick at home. So, you know, forgive yourself, have some grace for yourselves. Like, this is a lot to go through. And anybody could use some extra support during that time. We have behavioral health. We also recommend support groups. But I think the first step is really having enough grace to go, okay, yeah, I'm not a superhero. None of us are. And to realize all these circumstances that can contribute to mental health problems.
Thanks. I do want to take another question from the audience. We have Veronica from Florida.
Hi, everybody. Thanks for having me. Yeah, my husband is a patient at Moffitt, and in this journey, mid-40s, first time I ever heard the term palliative care. And so I'm wondering if you could just kind of explain what that means, because I think at Moffitt it's actually called something different. So, and then, does your medical team recommend it, or do patients need to be a little bit more proactive in knowing what it is, asking for it, and making sure that we get the resources that it provides?
Yeah, great question. Thank you so much. This is something very dear to my heart for a lot of reasons. So palliative care is something that I think there's a lot of mystery around. It's not well understood by a lot of groups, and it gets mistaken for hospice frequently, and they're completely different things, but they can go hand in hand. So palliative care really is talking about that whole person, and really it's about that symptom management and taking care of those pieces instead of just seeing a nephrologist for your kidneys and an endocrinologist for something else. Palliative care really does a good job of asking those questions. What are your goals of care? What are all of your symptoms? And they're really kind of like the collector of all of those pieces about working with your medical team to make sure that those specific things are being addressed to make you feel as good as possible. And it doesn't have to be in a terminal situation. I think best case scenario is that every patient with cancer gets just see palliative care as a consult. It's not realistic just because there's not enough providers to do that. But as someone who has a lot of symptoms, a high symptom burden, or is just not coping well, that's the person that really should have priority for palliative care, in my opinion. I'll kick that over. It shouldn't have to be patient driven, but you can always bring it up. But I'll kick that over to Gigi because I'm interested to see what you guys call it there based on Veronica's statement.
Yeah. So she's right. We do call it supportive care and not palliative care. Typically, I mean, I will never say to a patient, no, don't advocate for yourself. Yes, bring it up. Ideally, every person who walks in the door should have a supportive care conversation, like Marge said. In reality, in practice, it doesn't happen because, we're so stretched thin. So yes, we want everybody to see supportive care, but, ideally, the people that will see supportive care are people who are having other symptoms like pain, sleeplessness, things that, you know, we in the clinic can't manage completely. So it is, like Marge said, a holistic thing. Also, with palliative care, I prefer to talk about it at the first appointment with everybody, because I think it's important to talk about these goals that we have. And this has kind of been a common theme, what we've been talking about this whole time, is what are your goals? Like, are you trying to have a good quality of life and to be there when your child graduates high school? Are you, you know, just trying to say, you know, I don't want any like heavy duty meds. I don't want to suffer right now. I just want to carry on where I'm at and go to the beach every weekend. I mean, those things are the important things to talk about, and those things are what encompasses palliative care.
I think it's too, I mean, again, it is so different for each patient. You know, I have an example is I had a patient who, you know, was having issues where he was having fluid collect in his lung from his cancer. And so we were draining it fairly regularly. And we were talking to him about, you know, what is your goal of care? What's important to you? Because you hate to be really aggressive with certain types of symptom management. But his goal was to be able to sing in church, which means we needed to be aggressive because that was more important to him than having to come in for these appointments. And so I think it's really about, again, individualized care, holistic care, and really having those conversations. And palliative care is so good about having that, and they have the time for that. That's really what they do. And it encompasses so much, like you said, pain, sleep, mental health, just a variety of things. We're going to move into our next topic, which is around empowering patients for to be successful. And I'm going to start over with Nazi. What does self-advocacy or caregiver advocacy look like in your clinic? And how do you encourage patients to maintain an active role?
Well, we definitely want the patients and their family and caregiver to have a very active role. And it's very important for us. We have a patient-centered plan from the beginning till the end. So that means the patients are part of it. And I think that in this day and age, that there's a lot of information out there that they're not filtered, they're not through the universities. It's really, really important to direct our patients and their family to go to the resources that they actually give them the correct information regarding their situation. I am a big advocate in all the support groups. I think the support groups that is formed obviously by patients and the advocates are the best place to go to meet the patients like yourself, to get the information that we know it's correct. A lot of different pharmaceutical companies now, they do have and offer a lot of support through their organization for the patients, and they have nurses and they have a variety of support that they send to the patients. So I like my patients to know all of that available to them and pick and choose whatever it's easier for them, because sometimes the patients, they get a lot of support from their church or their community or their veterans, and they go to the VA and they have their support group there. So it really depends on what patients comfortable with getting it. I still think we have a lot of room to improve what we offer as a care team for cancer patients, for their mental health
Of their
and
time.
support and education.
Can you hear me?
Yes.
Okay, sorry, I think I had a lag there. Mark, are you there to ask a question? Oh, you're muted, Mark.
Yep.
There you go.
Okay. My question is very simple, because you mentioned time as being such a challenge. How can patients make the most of their time with the nurse during clinic visits?
That's a great question. I think one of the best things to do is to write things down you want to talk about ahead of time, so that number one, you feel organized, so that you don't forget your questions. And then the other one too is, if you feel like you don't have the time, is to let them know that, like, hey, I have more things I'd like to discuss. Can we have another meeting? Or like, hey, I'm going to go to infusion. Would you be able to come and talk to me? Or maybe talk to the infusion nurse, depending on what your topic is, or the clinic nurse. But really, again, that self-advocacy to say, hey, there's more things I'd like to talk about, because they'll find time, they'll make time. We are coming up on the end of this, and I do have just quick lightning round questions. I'll start with you, Gigi. What is one piece of advice you wish every single kidney cancer patient knew?
That Dr. Google is not the end all and be all of things, and that it is important to communicate with your caregiving team before you start to explore the internet and everything that they have. That's just freely available information that may or may not be true.
Yeah, I agree. What about you, Nazi? What's one piece of advice you would give your patients?
I actually like to give Mark a piece of advice. If your care team and place that you get your treatment and you go for a checkup, they have the electronic medical record, you can send messages ahead of time, and you can type it in your My Chart and send a message to your nurse practitioner or doctor. And if you're sitting in the comfort of your home like you are now, it's easier for you to think what are your questions. So you can definitely type and send it ahead of time and say, these are the things I want to ask questions and discuss during my visit. So then they're prepared with your answer and you won't forget anything. But what I like every kidney cancer patients or any other cancer patients to know from the beginning to an end is that this is not your fault. This is something that happened. It could be genetic. It could be just environment. Don't try to say, oh my God, I live so close by the power plant, or I have, this bad polluted air. We don't know. It could be a collective of everything, but stop blaming yourself, or start just say, how can we fix it, instead of why this happened. There are a lot of researchers around the world that they're working on these questions, that why it happened. So your job is to fix it with your care team and your help from whoever you can get help from.
Yeah, that's great. I would say my one piece of advice that I want every kidney cancer patient to know is you're not alone in this. Even if you don't have a support system at home, you have your care team, but you also have support system from groups like KidneyCAN and Smart Patients. There's lots of other support groups that are out there specifically to kidney cancer. And so just know that you're not alone. If you need somebody to talk to, if you have questions about your treatment and you just want to talk to another patient, there's excellent resources within kidney cancer, and please feel encouraged to reach out to KidneyCAN. They've put in some great links of places, and just know that you're not alone in this fight. And I'll pass this back over to Brian.
Great, thank you, Marge. Really appreciate that advice, and thank you, Gigi, and just appreciate all that you are doing. Nazi, thank you so much. Great advice. I was keeping notes here. I got too many of them, from moderation to not fighting with your body. There's a lot of great stuff there. I hope folks back at home can share this with people that that might benefit from hearing from this. But as you saw, probably the link to the community social should be in. It's also on your calendar invite. We welcome folks to come over there and hear more about it. It's ironic, I guess, to some extent that the Smart Patients community is how KidneyCAN got formed. So it's because of getting together with other folks and talking about these kinds of issues. So it's great resources out there. Please tap into them. Can't thank our sponsors enough of AO, BMS, ASI, Exelixis, Genentech, and Merck. Appreciate you sponsoring this event. The replay of this is going to be on YouTube. It'll probably be up, I think, by the end of the weekend. Please feel free to share it with other folks. I think there's some great takeaways here. If you have your calendars ready, coming up in early February, we're going to have our next town hall. We don't have an exact date, but we're going to have a powerhouse lineup with Dr. Naomi Haas from Penn and Dr. Dan George from Duke, talking about looking back and then looking forward on our research. So if you can join us, keep an eye out for those dates. And then really want to say to those folks, think about Spring Advocacy Days. We're going to be back on Capitol Hill between now and then, but also March 9th and 10th. We're going to be heading back into DC and also doing hybrid calls, Zoom calls with folks on your elected representatives. If you can, keep up to date on our campaign to restore the research funding. You probably all heard that we're on the verge of the government hopefully reopening, and which means that there could be some movement with several bills, including the defense and the labor HHS bill that have funding for kidney cancer research specifically in there. So we're looking forward to helping get that across the finish line. And don't forget, Giving Tuesday's coming up. Would love to hear from you that way as well. So thank you again, Marge. Really appreciate all that you all are doing. Nazi, thank you so much. Gigi, and all those who were able to call in and ask questions, and hope you got your answers. Feel free to join in the community social right after this if you have time. And otherwise, have a great Thanksgiving if you can, and a great New Year. And appreciate you all taking your time today. Thank you.